You have to sit up here by me. I will.
All right, good morning. Welcome. I hope you all had an enjoyable night. The weather certainly didn't suffer. This morning we have actually a fascinating group of panelists and lecturers, all but Dr. Chopra, our vascular surgeons, a very renowned international group. The first to speak, however, is Dr. Raju. He runs a Rainey Clinic in Jackson, Mississippi. He is renowned in the world of venous disease. He's a former president of the American Venous Forum. I have not met him before, but it's a real honor to be able to introduce him to you. Dr. Raju.
Mr. Chairman, Dr. Thorpe, Dr. Bush, and friends. One of the common things that is frequently said that when there is reflux, it disrupts column pressure and restores column pressure with onset of reflux. That is simply not true. You can do a you can set up a simple setup like this as a collapsible tube, and then you have a valve. You can open it and actually measure the pressure at the bottom. Of course, it's free reflux. Now, the pressure will not become normal till reflux stops and this balloon-like balloon distance. In other words, just onset of reflux itself will not restore column pressure. Reflux has to stop before column pressure recovers, which means the time for column pressure to recover, to come back, becomes abnormally short. Now, you have a gradient, of course, for reflux. And if the gradient disappears, the moment the reflux starts, if the pressure comes back, there's no gradient, reflux is going to stop, right? So this is a myth that reflux immediately restores column pressure is simply not true. Now, calf pump mechanics is much more complex than most of us realize. Let's say there is a popliteal valve here. That's a resting status. The pressure here above the valve is 65 millimeters of mercury. And below it is 66, so the valve is open, there is ongoing flow. When the calf pump acts, the popliteal valve closes. Now, it has been shown that the femoral valve and all that, they stay open. Most of the closure occurs here at the popliteal valve. There is ejection, and all the vein segments below collapse. There is some blood left over, and if you look at the pressure there at the top of the column is 0, right? I mean, it's top of the column, it has to be 0. Let's say that the column grows up and touches the valve. It's still 0. Right here, a little bit below, it will be 10 millimeters. And above, the pressure is 65. Just because the column grows and touches the popliteal valve, the valve is not going to open because there's not enough pressure to pop the valve open. What has to happen is continued arterial inflow into the venous segment, and then this segment has to balloon and create tension. Just the column height alone is not enough. This wall tension blowing up like a balloon is what creates the pressure necessary to open the valve. So if you think about it for a second, you realize that it's not all about reflux. It's also about wall tension, which means if there are abnormalities of compliance, then this mechanism is going to be seriously affected. That is air plethysmography, which measures volume recovery, and that is pressure recovery. You can see that the volume recovers all within a matter of seconds after calf pump action, but pressure takes a long time to recover. The difference is due to the asymmetric volume-pressure relationship of veins. And this also is a measure of compliance. The difference between RT and VFT is a measure of compliance. Now with duplex, you can measure or quantify reflux. So you know the time average velocity, you know the duration, you can measure the size of the vein, and that is reflux per calf diastole. Every calf pump action, you have reflux, you can quantify the amount of reflux. Now, this is a big vein, and I believe the diameter here is 6 centimeters, 6 millimeters. But the duration and velocity are also important. So the reflux volume here is only 4.5 milliliters. That's a small amount of reflux. You need something like 30 cc's or more to upset the calf pump. I'm sure you have thought, what is this about reflux? I mean, what's damaging about reflux? Is it just the reflux is in the reverse direction it does something? No. There is something called the reverse direction may be important, but at the present time, all the evidence is that reflux acts through the calf pump by shortening the recovery time. So this is a small amount of reflux, and you need about 30 cc's to upset the calf pump. Now, what about the size and the amount of reflux? If you take the size, and this is calculated 7 centimeters per second, and the duration is 10 seconds, that's about what you see. That's moderately severe reflux. And if you have the same amount of reflux in these various Saphenous sizes, you will see size makes a difference. With this setting, because of the area is pi r squared here, the volume doesn't really become significant till you go after 5 millimeters. This means to have significant reflux, you need to have at least a 5 millimeter Saphenous vein. Now, the reverse is not true. You can still have a big vein and end up with a small reflux if the duration and velocity is relatively small. Now, you can look at the Saphenous vein and you can calculate the potential of a given Saphenous vein to provide reflux from Poiseuille's law, and which is pressure gradient pi r4 8 mu L. I won't go into detail, but that gives you the maximum reflux possible in a Saphenous vein of a given size. And the green line is the maximum reflux possible for a given size saphenous vein. The red dots are actually, I should say blue line, not green line. The red dots is the actual measured reflux in various saphenous sizes. Now, in a saphenous vein less than 5.5 millimeters, you're simply not going to get big volume of reflux. The maximum you are going to get is something less than 30 cc's. In other words, small saphenous vein, you are not going to get big reflux. But the converse is not true. These are all large saphenous veins, and you can get small amount of reflux or big amount of reflux. What's the difference? Why? It's because of velocity and duration, but also because of perforators. Remember, I said the saphenous reflux acts through the calf pump, and the reflux has to go through re-entry perforators into the calf. You can have a large saphenous vein, but if you have piddly amount of perforators, it's simply not going to reflux enough to affect the calf pump. Now, there's such a thing called reflux channel. Using Poiseuille's law, you can actually virtualize the size of your reflux channel, which will be much smaller than the actual saphenous vein. And you can see the reflux channel doesn't have to increase very much before the volume of reflux becomes quite impressive. But the saphenous vein doesn't, it has to enlarge a whole lot. This slope is much steeper than this slope. Again, this shows that it's not the saphenous vein size itself, but the perforators that's important. Now, this shows VFT, which is the ambulatory venous pressure recovery time. That's a reflux volume. We have a line around 30 cc's right here. 20 seconds is normal VFT. Anything below 20 is bad, above 20 is good. Here, anything below 30 is small reflux. After 30 is big reflux. Now, you can see if the reflux is less than 30, the recovery time, or VFT, is normal in lots of patients. But there are about 17 limbs where even though the reflux is 30, less than 30, still end up with a problematic or abnormal VFT. On the other side, these are large volume reflux, all these patients. And these patients here, large volume of reflux, end up with an abnormal VFT as you would expect. But there are some patients here where, in spite of a large volume of reflux, there is normal VFT. So the calf pump has compensated for this large volume of reflux in these patients. The calf pump is abnormal in these patients, resulting in a VFT, even though the reflux volume is pretty small. So we look at the calf pump here, and it has got compliance, that's important. The tank size is important. A certain percentage will get ejected volume, that's important. So if you have reflux, suppose you have a big tank, reflux becomes compensated because everything is relative to the tank size. You have to upset the calf pump. So a big capacity in the calf will compensate for reflux. Suppose the compliance is very good, that will also compensate for reflux. Suppose the ejection is very good. You may reflux 50 cc's, but if your ejection increases by those 50 cc's, reflux would have no effect on the calf pump. Just the reverse here, decreased compliance, decreased capacitance, decreased ejection volume, all will magnify reflux. So the previous slide, this is all abnormal calf pumps to begin with, and even a relatively small volume of reflux is the last straw on the camel's back, so to speak. Patients become symptomatic. And here, there's so much calf pump compensation, in spite of a lot of reflux, calf pump is okay. So the moral of the story is, reflux by itself is just a name. How it affects calf pump, if you want to become discriminating physicians, as I am sure you want to, you have to study the calf pump, which means doing air plethysmography and doing ambulatory venous pressure measurement. Thank you.
Thank you, Dr. Raju. That was great. I had a patient in my office yesterday with a 1.2 centimeter saphenous vein, and we struggled to demonstrate reflux in it, and I now understand why. Our next speaker is Dr. George Martinez. He did his vascular training at the Jobst Clinic in Ohio, practices in Puerto Rico, and he's going to talk to us about nerve injury and other complications from thermal ablation.
Well, let's continue on the complication issues from yesterday. Like I said, I got nothing to disclose. So the complications I'm going to talk about today is mainly the late complication, infection, paresthesia, and excessive pain. So excessive pain can be a problem, and I'll tell you that most of the people that complain of a lot of pain after these procedures, they just have a weird idea of what they were expecting. You know, they were expecting absolutely no symptoms, and you just have to explain to them, you know, that it is a post-surgical issue, that you will have some sensations, etc. So post-procedure pain can be a traumatic or thermal nerve injury. It can be causalgia, reflex sympathetic dystrophy. Reflex sympathetic dystrophy, it's thought to come from injury of the nerve that surround the vasa vasorum. You can have a tense hematoma or infection, which if you have somebody having pain due to a tense hematoma, you will see it, and you know that would require drainage. So like I said, excessive pain is rare. Most of the time you will discuss it with the patient, explain to him that it's normal to feel this type of sensation after surgery. Specifically, some people will come at 4 to 6 weeks and say, I have this pulling sensation in the area where you treated, and that's as the great saphenous vein get fibrotic, you will feel that pulling sensation. You just have to give reassurance. Some analgesics, and occasionally, if the pain persists, you can consider performing a nerve block under ultrasound guidance for that specific dermatome, or if it's causalgia, which some people will treat lidocaine patches, neuronting, etc. If none of that works, then the correct treatment is ethanol injection of the nerve ganglion at the level of L2, L4, which I hope nobody gets this, because causalgia is very painful. You can't touch them. You can't breathe on that area, because even breathing causes extreme pain. So paresthesias are common, not that common, but it's reported up to 10%. And you can have 3 types of paresthesia. You can have the painful paresthesia, which is the more troublesome, just numbness in the area. And of course, you can have motor deficit, which I'll explain to you how you can cause motor deficit during this type of procedures. So paresthesia etiologies, traumatic with a needle or catheter induced. That's basically poor manipulation and poor technique of the catheter. You can handle it incorrectly and just damage a nerve as you push through. And of course, with the needle, you need to be careful, because you can sever a nerve. I don't know if you ever had this, but I receive occasionally patient. I get a consult because they have numbness in the leg and pain, and they had a cardiac cath or any vascular procedure. And when I go and evaluate them, what I realize is that it's most likely because there's no hematoma, there's nothing in there. Most likely they just severed a sensory nerve while entering with the needle. So it can happen, and the key to that is, to be careful where you apply your tumescent anesthesia. It can be traumatic during phlebectomy. So if you're doing phlebectomy, you know that occasionally you're pulling the vein and you hear, ah! And then when you pull out, you see a piece of nerve that comes out with your piece of vein. So, that's very painful. And of course, if you pull a nerve, you most likely will get a paresthesia from there. And then you can cause terminal nerve injury, which I hope to explain how to avoid it. So preventing, you need to know the anatomy. Like I said before, entry point planning is key, specifically when dealing with the saphenous or the sural nerve. And ultrasound identification of the nerves can be done. There's a good technique, good paper from the European Journal of Vascular Surgery that explains how to identify them and where they are and the proper technique to do it. So, and careful technique applying tumescent anesthesia is always important to avoid needle injury or burning of the nerves, okay? So really, the most common nerves that are affected, basically the femoral nerve, the saphenous vein, and the sural nerve. As you see, these are all superficial. The sural nerve, right at below the mid-calf, it runs very closely related to the small saphenous vein. So that's the one I suggest that you recognize before you plan your entry point. And then once you recognize it, you try to move it away as you apply your tumescent anesthesia. The saphenous nerve, I don't know if you've ever seen a great saphenous dissection. Once you go below the knee, you start seeing all the fibers of the saphenous vein directly related to the vein. They are on top of the vein. So if you start your entry point way below down here, I'll tell you what, most likely you will get a paresthesia on that patient. So if you want to avoid a paresthesia of the saphenous nerve, the key will be to start just below the knee and above. Okay, because that's a place where the saphenous nerve goes directly in contact with the vein. So the other nerve that you can affect, and it's not common, but it can happen, like I said, with a needle or terminal injury, will be when treating the anterior saphenous vein or when applying tumescent anesthesia near the saphenofemoral junction, which is the femoral, a branch of the femoral vein that it's the femoral nerve that is cutaneous in that anterolateral thigh. So like I said, the femoral nerve will cause numbness on the anteromedial thigh, saphenous nerve in the anteromedial leg and dorsum of the foot, and the sural nerve will be in the posterior leg and plantar area of the foot. So how to prevent the paresthesias? If we're talking about the femoral nerve, you should be able to see it on ultrasound. It's small. You can follow their branches. And if you're dealing with the anterior saphenous vein, and of course try to apply it enough tumescent to get everything separated. If you're avoiding paresthesia of the saphenous nerve, will be mainly selecting proper entry point. Remember, just below the knee, if you keep going down, then you're gonna hit it and damage it. And lots of tumescent anesthesia and the sural nerve. There's a good technique that has been described, like I said before. So here's the area of where the sural nerve is. And you can actually see the nerve. It has a halo around the tissue. It's really nice. And if the proper way to do it is you find it at the distal third of the leg. It's closely related to the vein. And then you follow it up. And when you see it starts separating, that's the place that you want to plan your entry point. Okay? And then once you have located the nerve, you make sure that when you're injecting tumescent anesthesia, you put your needle between the nerve and the vein so they separate even further. Sometimes, I know it works.
Is there a video?
Oh, there you go. Ah, I see what's going on. If you put your finger where the signal comes out, it doesn't transmit. Gee. So, um, so here's as you come further up, you can see that that they separate within the fascia. And here's an example on how, if you're coming up and you follow it, you will see the fibers of the nerves between this perforating vein and the small saphenous. So it's very important that you identify the nerve below and come up following it. And the same technique you can use for all other nerves, okay? So the saphenous, you probably will not see it clearly in the below area, in the below knee area, because it becomes a lot of fibers intertwined around the vein. But above the knee area, you could probably see it, and in the most part, you see it as slightly posterior and towards the fascia. And you can see it with your ultrasound. Identify it and protect it. So here's the one that I will tell you. That this is a complication that nobody wants to have. It's motor deficit. So the common peroneal nerve, which is a branch of the tibial nerve, comes very close to the skin and unprotected from any muscle fascia around the knee. As you can see, this nerve comes around, and so at the level of the fibular head, the proximal fibular head, it goes very close to the skin. Okay, so this is something that you might want to keep in mind if you ever see varicose veins in that area, just to make sure that you don't get too aggressive. I'll tell you what, this is nobody has published motor deficit after this, but I know it had happened. I've heard it from colleagues, so make sure that if you're in that area, just be very, very careful. The other nerve that can be damaged are some motor branches of the femoral nerve, which can be damaged while doing ablation of mainly of the anterior saphenous. So it's, like I said, these branches are easily visualized on ultrasound, so you might want to consider just looking at them or just staying away from that area. It might cause a little bit of weakness on hip flexion. So like I said, the common peroneal nerve causes foot eversion, dorsiflexion, and toe extension. That's the paresthesia I think nobody wants to have because of foot drop. It's a devastating issue. And the femoral nerve, it might go... nobody, they might not really detect it, but if you do proper examination, you might identify it. So recommendation to avoid common peroneal nerve, I'll tell you in that area, if you're going to do phlebectomies, use a lot of tumescent anesthesia, put the needle behind the vein and get it closer to the skin. Just don't go any deeper. If the guy is very skinny, just avoid phlebectomies in that area and forget about it. Okay, so the femoral nerve, just use plenty of tumescent anesthesia. To finish, cellulitis and abscess, recommendations to prevent it is very important. These are just standard sterile techniques. No shaving. You should use clipping if you're gonna do that. If you're gonna ask the patient to shave at home, do it at least 48 hours before. Okay, don't do it the same day. Don't do it the day before. Do it at least 2 days before. Okay, that'll give time for the skin to heal. And you need to examine the skin. If you see some eruptions, some areas that look infected, you know what? You can always bring them back another day. So if you see pustules, forget about it. Okay, so make sure, and then if there's an ulcer, clean that ulcer separately, cover it, and then clean the rest of the area. So strict sterile technique when you're doing this. Don't get confused with a superficial venous thrombophlebitis. I get patients admitted by the ER physician because they had an area of SVT after the procedure. I go in, there's no fever, no white count, there's just nothing. This is just normal inflammation after the procedure, so just leave them alone. But of course, if you see fever, you want to start them on antibiotics. And when you see a phlebitic vein, you know how a phlebitic vein looks like. And if you see a lot of erythema and excessive tenderness, you know what? It might be an infection. So treat it empirically, get a WBC count, and just give close follow-up. Okay, so recommendations, attend PO antibiotics first. If not responding, give IV antibiotics. You perform imaging if you see an abscess, IND. And to finish, pre-intervention planning will avoid some of these complications. Use the probe and know how to identify the nerves when you have to. Plenty of Tumescent anesthesia. I can, just be liberal with it and have extra bags on the side. Remove re-entry like I did said for the previous session. Look for the nurse and strict therapy techniques. Planning, planning, planning. Thank you.
So that was a great talk on how to stay out of trouble. Excuse me. The old surgical axiom is it's far easier to stay out of trouble than to get out of trouble. So a little bit of forethought goes a long way. Our next speaker is Dr. Nieves. He's a vascular surgeon from Bogota, Colombia, and he's going to talk to us about the South American experience treating superficial venous disease. Dr. Nieves?
Oh, well, good morning, Dr. Bush, Dr. Thorpe, friends. This speech is about focus in CIAP-C1 and the other branch, the CIAP-C6. In the CIAP-C1, the telangiectasias and the superficial veins problem, in South America we have interesting experience and research. In Argentina are the thinking doctor. In Brazil is Dr. Kikuchi is in the table with us, and Dr. Kazuo in Bogota is the Dr. Ulloa, who works very well the endoluminal occlusion foam. But in this case, we have an venous score from the Miyake doctor, and it's very useful, especially we have the patients and coming with the aesthetical problem. This work is about the fluoroaesthetic area. In this chart, we can see in this column no telangiectasias, the other column patients with telangiectasias, and the other one telangiectasias with feeder veins. It's very important, the feeder veins in the cosmetic treatment of these problems. In this part, no varicose veins, some varicose veins and reflux on saphenous vein or perforans. And we have one classification to 1, the normal patient, no telangiectation and no varicose veins, to 9 in the most severe case. And it's perfect for the patient because he can see what is his problem and it's easy to explain the treatments. In this case, the number 2, any kind of sclerotherapy was good and worked very well. And 3, 4, and 6 works very well. The CLAX technique is the name of cryolaser and cryosclerotherapy. Or in some cases, this is a Brazilian technique. And in other cases, when the veins are more bigger, I prefer use one Spain technique is foam polydocanol and laser, and works very well. In the 7, 8, and 9, the surgery and more aggressive attitude works very well. You can choose endovenous laser, endoluminal occlusion foam, or a mixture of 2, or microphlebectomy, whatever. And we are focused in 2, 3, 4, 5, and 6 in the score classification. For cryolaser and cryosclerotherapy, what we need? We need some device to see the vein. Works very well the vein viewer. There are other marks. Especially for try to find the feeder veins. We need an NDJ laser. There are a lot of marks. This wave is the necessary. And some device to cool the skin because it's a little painful. There are doctors who have the Cryo 6, or I use ice-cell packs, it's more practical for me. And in the CLAX technique, we use the straws at 75%. And the foam technique with laser, we use polydocanol. There are some literature about the technique and explain very well what is the use. We have this patient. Is the most common patient that we have. This Fitzpatrick maybe too, very wide. You can see the telangiectasias and the feather veins. You don't need any machine for this. With vein viewer, you can see better the feather veins in this area, a lot of spider veins here, and continue, again, more feather veins. Okay, what is the procedure? We shot laser in this area, and after that, laser in the little telangiectasias, and close and put a little dextrose in the feather veins. And works very well. This is the picture of 2 months after the first treatment. Only one treatment in this picture. And the next, an important reduce of the telangiectasias. And it's perfect for us because the patient wants something that works well, and other thing is a less number of treatments. In this case, there are a little spider veins that are closing, and after 3 months or 4 months, it's going to be all closed. And we can work in other areas. This is the resume, the summary of the picture at the first day, 2 months later, and the feather veins here and are closed with this treatment of CLACs. We use some parameters, the spot size, the pulse duration, the joules that we need, and the hertz are very important, but these are resumed that the way that I use the laser, every laser is different, and it's important to know your machine. And in my particular case, when I have some bigger veins between 3 millimeters and 4 millimeters, I use the Spain technique. The difference here is that they put the foam first, wait maybe 2 minutes and 4 minutes, and after that, pass the laser under the veins and close very well. And the joules must be less than the CLACs technique, because in this case, there are changes in the foam polycanal and work better with less fluence of the laser. Okay, there are some examples. In more severe case of telangiectasias, in this patient, I use CLACs technique, the same, 2 sessions, and these the results are very well. I don't need to do punctions every week or sclerotherapy with treatment every 2 months or every month works well. This other case with more bigger veins, maybe between 3 centimeters or 4 centimeters, and I use foam and plus laser. And the results is interesting. This group of Spain have a recent publication in the Phlebology, the last year, and it's about 500 patients after 3 years, and the results are impressive. With this technique, the improvement was better than 90%, and compared with their patient only polycanal and foam, and the results in this case was an improvement of only 20%. The differences are bigger, and they use only 2 treatments in a difference between 3 weeks. Okay, for the other cases in this classification, 7A and 9, we have a lot of tools. Endovascular laser treatment. In this patient, I use only endoluminal occlusion foam and works well. In more severe cases, you can use endovascular laser treatment and foam if you don't want to do a microphlebotomy, and the result is good. You need to know the Fitzpatrick and what is the expectative of your patient. And this, the end of the part of this speech, is the other aspect of the superficial veins, is the CAP C6. We have a technique we call tapirs because we think it's very important to close all the axes of the hypertension, not just this part of the proximal hypertension venous, all the venous, we have some works closing with foam, the axial axis, the perforators, and the terminal veins that are very important. This is a case of an older patient of 85 years with a leg ulcer for the last 20 years. I did the closure of the vein with foam, yes, some punctions in this part, in the terminal veins, and put multi-layer bandage. And after, this picture is in the 2nd week, 3rd week, 5th week, and 6th week. We close all the ulcer. It's a faster result, multi-layer bandage and foam. But in the last patient, we are doing the proximal vein with laser because it works very well, and the last part of the vein below the knee with foam for the little veins. Other cases, this is the picture after 6 months of this patient, and all these patients closed before the 6 weeks. Okay, thank you very much.
Thank you, Dr. Neves. I think by the end of the day, you're going to see there are a lot of different ways of dealing with superficial telangiectasias, and you're going to have to figure out what method is going to work best for you in your practice. I've been given the task, I think I'm up, there we go, of talking about emerging endovenous therapies, STEAM, and beyond. We're going to talk about STEAM very quickly. It was first described in 2011 by Dr. Vanderbos, who did a sort of an early trial that showed that, in fact, you could use STEAM to ablate the great saphenous vein with some success. There's an American company, Venete, who was working on this, but they've abandoned their project in search of, or instead trying to work on developing their venous stent. A French company, Cerner, is still working on this. And at the end of the day, what you do is you have a catheter that's hooked up to a unit that emits saline, which has been heated with RF current to injure the inside of the vein wall. And I think the biggest advantage of STEAM, if there's any, is that the hope is that the STEAM will actually percolate through the branches of the saphenous vein and help reduce the need for subsequent phlebectomy or sclerotherapy. Unfortunately, though, or fortunately, STEAM still requires the use of tumescent anesthesia, and really kind of the future, or at least what's on the horizon, are the non-tumescent techniques. I would just make one note about using tumescent anesthesia is, while people say that it's very uncomfortable and painful, if you use a tumescent pump and you use a 1.5-inch 25-gauge needle, you can give plenty of tumescent anesthesia. It takes a little longer to give, but it's really minimally discomfort, or the patients experience minimal discomfort at best. So what we're going to talk about, though, are the new technologies. The current technologies that we're comparing them to are going to be RFA and laser vein ablation. And as you all know, they're safe. We know they have excellent long-term results. They do require tumescent anesthesia. We do know there's some issue with nerve injury, although in my practice doing this over 11 years and several thousand patients, I really can't ever say that I've had a significant nerve injury. And the advantage is it has predictable known reimbursement. The non-thermal techniques that we're going to talk about today are Varithena, or foam sclerotherapy, Clarivein, and Venocil, which is the newest player on the market. The advantages of these are that they require no capital equipment purchase. There's no generator box that you have to buy. You have no tumescent anesthesia, and none of the reports talk about any incidents of associated nerve injury. The disadvantages are that the cost of the catheters and canisters, we'll talk about briefly, unknown durability, unpredictable reimbursement, and what do you do with the varicose veins that are left after the procedure. So this is Varithena. It comes in this can. It contains 90 cc's of solution or of foam. It's mixed in this kind of complicated system over here. And at the end of the day, you have a foam that's 65% oxygen, 35% nitrogen. It has very, very small bubbles and so the risk of cerebral embolization is quite low. The technique is pretty simple. You put a little micro-introducer catheter in the saphenous vein around the level of the knee. You begin to inject foam. You watch it ascend through the great saphenous vein. When it gets about 5 centimeters from the saphenofemoral junction, you put down your ultrasound probe to stop it. You elevate the patient's leg so the foam rises and goes into the distal saphenous vein and the branch varicosities. When you're done, you do put a fairly complex compression wrap on the patient's leg, which is probably the biggest disadvantage to the technique. They leave this on for 3 to 4 days. They come back and see you, and you inspect their leg, and at that point inject any residual varicosities that have not gone away. Varithena was considered a drug by the FDA, so the usual things that we talk about, such as vein occlusion rate, were not what they had to show, but rather they had to show that patients got better in terms of their symptoms. So they developed this VSIMQ questionnaire, which looked at various things such as pain, aching, and the like, and they were required to demonstrate secondarily that the vein occluded, but primarily that patients actually felt better after this technique. And in fact, these are the results when they compared to placebo. They did in fact demonstrate there was significant improvement in patient symptomatology. Their vein occlusion rate is not quite as good as the endothermal techniques in that they had a rate of about 86%, but again, as a drug, as making patients feel better, they did great. And again, because the bubbles are very small, they're very stable, when you use this product, it comes out almost as toothpaste. It doesn't, like homemade foam, if you squirt it out within about 10 seconds, it's just liquid again. This product, a minute later, still looks like the foam that you injected. But they had no incidence of neurologic deficits, and in fact, their complications were quite rare. The one that people point out is that if you look there was a 4.7% incidence of DVT, but the vast majority of these were gastroc and soleal DVTs. And what they learned early on is you don't want to use this product in patients with large perforators connecting the great saphenous vein to the deep venous system, because the foam will go in there and cause a DVT. So that's Varithena. I think the biggest strength of the product, or at least the times that I've used it, are for patients with tortuous veins, for patients who've had failed endothermal ablations, where you're going to have a difficult time getting any kind of catheter thread throughout the vein. This product just slips right through all those little scars and cicatrix and has been quite an effective product for me. The next thing we're going to talk about is Clarivein, or MoCA, which stands for Mechanical Chemical Ablation. This was first approved in 2008 as an agent for physician-specified infusion of agents into the peripheral vascular circulation. This is a catheter. You can see them outside. It's a handpiece, and at the end of the handpiece is this little ball that's connected. And the technique basically involves placing this through a 4 French sheath, very small. You place the little ball to about 2 centimeters from the saphenofemoral junction. You turn the rotating ball on, and it moves at about 3,500 RPMs per minute, and you slowly withdraw, starting 2 centimeters from the junction, and then once you get 4 or 5 centimeters down, then you begin infusing sotradecol or polydocanol, and you withdraw at a rate of about, I think, 1 centimeter every 6 to 7 seconds until you've treated the entire length of the great saphenous vein. And this shows you exactly how that happens. The mechanism of action is that that little ball is thought to induce coagulation. It induces vasospasm. It increases the action of the sclerosant, and it assures even distribution. There's a couple articles that I read that actually looked at the endothelium following just mechanical ablation with the ball, and it's surprising there's not a lot of mechanical injury that you can document on at least electron microscopy. Kind of the initial study that put this on the map was published by Steve Elias, and she showed that there was basically a 96.7% primary occlusion rate at, I believe, 6 months of follow-up. Subsequent studies looking at the small saphenous vein showed a 94% occlusion rate at a year, minor complications along the way. And then this study, which actually followed patients out at 1 year, and they had an 88% occlusion rate. But I think the significant thing to me on this is that if you look, only 22% of patients required a subsequent procedure. And again, it's thought that maybe the sclerosant percolates through some of the varicosities to cause them to seal and reduce the need for subsequent phlebectomy or sclerotherapy. So as I look at this technique, that's the one thing that kind of intrigues me that I'm going to follow closely over time. The last device we're going to talk about is a VenaSeal device. They're also here. And this is a glue, the cyanacrylate. I still can't pronounce the word. But it goes through a 7 French sheath here. And if you look at the schematic here, the way this works is you place the sheath similar to a laser catheter about 5 centimeters from the saphenofemoral junction. Every time you squeeze the hand device, it ejects 1/10 of a cc of glue. The initial procedure you hold for 3 minutes at the saphenofemoral junction, inject 2 or 3 pumps of glue at that level, and then you keep backing the catheter out, I believe 3 centimeters at a time, giving an additional squeeze of glue, holding compression down the leg. And the way it works is not only does it actually, in theory, glue the vein, but it induces an inflammatory reaction, which is eventually going to lead to endofibrosis. The remarkable thing about this product, and I have not personally used it, is that on average they use 1.2 or 1.4 cc's of glue to seal the entire saphenous vein. It sounds remarkable, so remarkably little, it's hard to believe it works. But in fact, this was published by Jose Almeida, looking at 2 years of follow-up in 38 patients with an average vein diameter of 8 millimeters. And in fact, they had a 90% occlusion rate at 2 years. A European trial, similar size vein, they had a 93% occlusion rate at 1 year with minimal complications. And this is the VenaSeal trial that was a randomized trial that Covidien put on, or Medtronic, comparing VenaSeal to ClosureFast. And you can see at 3 months, the VenaSeal had a occlusion rate of 99% versus 96% for ClosureFast. Interestingly, though, when you looked at procedural pain, it's very similar to the amount of procedural pain that you had with ClosureFast and the Tumescent Anesthesia. And I suspect that that's because it's just pretty uncomfortable for a patient to have an ultrasound probe compressing his vein for several minutes as you're doing it. But the patients got significant improvement. They just published the 1-year results, or they didn't publish, I actually got it in a press release. And at 1 year, the VenaSeal and the ClosureFast occlusion rates were both 96.7%. So it appears to work very well. The one thing I would just point out from my practice, I do a lot of phlebectomies, and this is a trial that looked at laser without phlebectomy versus laser with phlebectomy. And you can see that if you looked at the patients who had laser alone, 2/3 of them required a subsequent phlebectomy. In my practice, roughly 2/3 of the patients that I treat have a phlebectomy at the same time as their initial procedure. So I'm not quite sure how to incorporate these tumescentless techniques with my ability to try to treat patients all at one time in a very efficient manner. The other issue is a cost. You all know what your costs are for your laser catheters and your ClosureFast catheters. You can talk to the reps outside about the cost of this, but I will tell you that it ranges anywhere from $750 to $3,000. So it's kicked everything up a notch. Reimbursement is fairly unpredictable. So in conclusion, the techniques appear safe and effective. Clinical trials suggest occlusion rates at 1 to 2 years may approach thermal techniques. I think currently cost and reimbursement issues limit their use, and I think some long-term randomized trials are necessary. It's been an honor for me to present at this meeting, but I have to, just as a aside, I think that when laser vein ablation and ClosureFast were paradigm shifting in terms of venous technology, it took everything from the operating room to the office. Whether non-thermal techniques are paradigm shifting or not, I think is yet to be determined. As I said, it's an honor to present at this meeting, but it was a real thrill for the Chicago Blackhawks to win the Stanley Cup this year and for my daughters to be able to hold the cup afterwards. So, thank you very much. Dr. Romy Chopra is going to come back, and he's going to talk to us about perforators, the age-old question.
Good morning. I'm going to try and keep it simple in line with understanding, again, the pathophysiology and how we treat this. And it's really, one is making it easy for ourselves, but really making it good for the patient. And the very first question that comes, and what we're going to look at with the right patient, the tips and tricks, and I'll show you a video of how we actually do it and walk through it. And the question is, why do we treat perforators? Because there's evidence that the incompetent perforator veins play a major role in the pathogenesis. And we talked about it yesterday with the pressure from the deep system coming through the incompetent perforator. And as many as 66% of limbs with the skin changes in the SEEP classification from 4 to 6 have an underlying incompetent perforator that's in the game. And it becomes important to understand where the pressure is coming from and then stop that source of the pressure. A lot of times, treating perforators is like spot welding. And really about, I tell my patients this, I even show them pictures if I can, and with ultrasound at that time. So the foundational principle is you have the deep veins, you have the perforator, and whatever, if this valve breaks, it's going to flood a certain region. And you're going to see the changes in the skin and the tissues. If it's lipodermatosclerosis, ultimately the skin breaking down. And oftentimes, the pressure is a combination of saphenous truncal reflux, and depending on what the flow patterns are there. So obviously, if you have a large source of reflux from the saphenofemoral junction, you want to understand where else it's coming from. A lot of perforators actually are bidirectional, and there may be flow from a reflux above coming back into the deep system. Perforators can be either directly from the deep up to the reticular and affecting the area, or going through the saphenous vein and then coming out. Oftentimes, the one that connect into the saphenous, lesser or greater, if you connect that whole pipe, the rest of it will shut down. So I'm going to try and show you the ones that are isolated. Kind of understanding that a lot of the perfs will have an artery close to it, especially as you get closer down on the leg, posterior tibial. But you can see perforators in the lateral side of the thigh, medial thigh, below the knee, ankle, foot, depending on where the pressure is coming from. So as you create a map of the venous hypertension, sometimes you'll see, if you have a patient like this, that there's recirculation going on, the pressure rises here. In this case, the flow is out from here, going back in. Oftentimes, you'll want to do both. The key is ultrasound. Once you get the ultrasound and find out where the leak's coming from, you don't want to go deep, but you want to be able to hit this right at the fascia where it is. I'll try and do both, but oftentimes once you do the first one, the second one may or may not be easily accessible, spasm in that system, or just when you give the anesthesia. Oftentimes you don't need tumescent in that region, just enough around the tip, depending on what you're using. Want to make sure there's no obstructive process going on in the deep system. And when there is an obstructive process, that is really your relief from the deep system. So shutting things down at that time can make things worse. Again, something to be careful. So now the question is, which perforators to treat? Obviously, the ones that have reflux. More than 500 milliseconds, some use a second. Size, it depends on whether the patient's standing, legs elevated, they're hydrated. So size is always not that important. But most of the ones that are refluxing will be fairly large. You'll end up looking at SEEP 4 to 6. However, you saw some cases yesterday as well, where if you have an area that's being fed by the pressure, whether it's telangiectasias, reticular, or even varicose, you can still shut down the perforator as part of your normal treatment, so it's not only for deep wounds. Traditional treatment, open surgery, I don't think I recommend that, or the SAPS transfascial procedures. Some of these are really outdated now. Ultrasound is the absolute key. If you can't do the ultrasound, can't identify it, treating it becomes hard. The only FDA-approved device is the Covidien and Medtronic, now Medtronic RF ablation device. Lasers can be used, it's off-label. And I know certain companies have gotten into trouble for trying to market that. This is really spot welding. So with ultrasound, you find where the spot is. They have a certain technique that they propose, but most operators will find a way to adjust it to what works for them and how much they need to use. Could you play that video, please? So it's an actual case as I'm doing it, so I'll probably help out. You got the volume on that, please?
So I have for you now is show you perforator ablation. So there's a refluxing perforator. It's a young lady who had greater saphenous vein, a lot of reflux, treated that. She's doing a lot better. Her pain, swelling has significantly decreased, but we're seeing that there's still some veins, some residual disease, and we can see a large perforator that's feeding an entire network of veins. Some folks like to just sclerose that with foam, but I don't like to do that because the foam goes into the deep system. So we'll do an ablation of that segment just at the fascia, which we'll look on the ultrasound in a minute. So I'm doing the ultrasound now, and you can see on the screen in a moment where I find the perforator, and there it's leaking into the large branch, and that branch obviously goes up and is feeding into a whole bunch of other veins, that varicosities and reticular veins. So I'm going to come back and then take care of that perforator. So it's very important to identify where the fascia is and where exactly that perforator is feeding in. And I can see the fascia right there, and that's where we're going to go in with the ablation. So I've adjusted my probe position so that the vein is at the edge of my screen. As you look up on the screen now, you will see that there's the fascia, there's the perforator coming in, and I will now position my needle in such a way that it goes right into that fascia. So this is how it will be once it's inside, along that's the angle, that's the pathway, and if you look at the screen, or the ultrasound screen, you'll see what I'm talking about and how I want to position that, and that's how I'm going to go in that direction. Yeah. So I'm giving lidocaine a little distance away so that I can get into that frame. And if you look at the screen on top, you'll see where the ultrasound, the lidocaine is coming in. And that's where I'm going to bring in my fiber from that angle. So with that angle now, I'm going to go in. If you look at the screen, you'll see I'm now basically spearing that portion. And the reason I know I'm in the perforator is when I look at the machine below, you'll see that the impedance is in the 280 range there. And that's when I know that the impedance is low. If I'm outside, the impedance would definitely be much higher. So oftentimes I should get heme coming right back, but I may not. And that just means that I have something at the tip of the needle, but as long as the impedance is good, I know I'm in good shape. And if you look on the screen, you'll see that my needle tip is right at the fascia, and the heating element is right at the level of the fascia where I'm moving the tip of my fiber. So I'm going to give a little lidocaine now right around the spot. And so now if you look at the screen, you'll see I'm giving the lidocaine right around the tip where the filament is and where I'm going to do the actual heating. Alrighty.
That ultrasound.
And one of the things that happens if you look at the RF generator below is as soon as I give that, the impedance drops further. And I know that I got adequate anesthesia around it. The assistant then presses on the RF power button. She keeps it on there. In case the patient feels something, you stop it right away. So far, nothing, because that is a good 83.6 degrees centigrade. If she felt it, she'd either hit me or tell me, one of the two, but definitely at least scream a little bit. And so far, so good. Assistant takes a finger off that, it will go up to 4 minutes. And if for any reason this is in the wrong spot, as in not still within the blood vessel, the impedance goes up and the machine stops by itself. So you'll see as the seconds go on, the impedance has stayed in that range. And we'll go back and look at the ultrasound screen, and you can see the location where the heat is being applied, and it's right in the spot where I want it to be. So you can see we're now at just about 2 minutes, and if you go up to the ultrasound monitor, we'll see we're in the same spot and that is still continuing to apply the heat, but you can see the coagulum around it and the echogenicity. If I pull this back or it's in major tissue, the impedance would go up and the machine would stop on its own. I do this at 4 up to about 4 minutes. Occasionally, if there are branches around it, I'll foam them at the same time, but not today. We'll just ablate this for now.
You can stop there here, please.
So as you see, we're starting to reach just around 4 minutes here. And if you look at the ultrasound now, you'll see that the branch that we had before is definitely not.
Excellent, thank you. So as you can see here, oftentimes one important trick is if you're going to give foam, I kind of look at it as spot welding so the foam won't go deep in. And then if there's a network, I get that whole network with foam. If you're going to do that, you want to put the butterfly in first, because once you apply the heat, there's spasm, it's very hard to get into it. Oftentimes you may have a network of 2, 3 different perforators in the region. If you're going to do that, sometimes you'll get in the second one, but you may have to stage it because you won't see the second one as well. If there is a wound, I would not recommend that you do it through the area that's infected. Maybe like Dr. Bush does, put the foam first, get that area, get the wound to heal. One case that I did, and I think I mentioned this yesterday on the panel, we went through an area that was lipodermatosclerosis, very significant, big perforator, and he got an infection that kind of never seen before. It almost went down all the way to his muscle. It took him months to heal. So that's a word of caution. The foam is all the standard foam techniques you've heard, Sotrodecol, Polidocanol. You can use some of the newer ones. The real issues are watch for the adjacent artery. You can hurt the skin, be careful about that. Make sure the deep system is patent. Don't go through a contaminated area. So choose your patients carefully. There's a lot of different options. Wanted to stay on compliance, so we didn't talk much about laser, but there are enough people who use lasers, including myself. We can put the fiber through the needle itself. I don't think anybody really does open surgery on this anymore anywhere. But ultrasound, doing it yourself is absolute key, and going from there. And depending on what you're treating, but most of the time, I will do the truncal lesions first, make sure the overall pressure has decreased, and go from there. Thank you so much.
All righty, Romeo, thank you very much. Our final presentation before our break, Dr. Ron Bush from Florida is going to show us how to do a phlebectomy. Ron?
Thank you. So this is going to be hopefully very quick. I don't want to suffer you through the pain of watching me do something. So why we perform phlebectomies, I think it's, in my opinion, it's essential. When we do endovenous ablations, I always do the exit phlebectomy. And the exit phlebectomy is the first little dilatation you see. All veins, all varicose veins are one branch, okay? Every bump you see is a valve. And if you don't do an exit phlebectomy, you're going to hit trapped blood sometimes. Other times, the patient's going to come back. The veins are still there. If you do an exit phlebectomy, at least you decompress the distal vessels, and you get a lot better cosmetic result. You can actually treat them with foam later if you want, or do a little phlebectomy. But I think it's imperative to do an exit phlebectomy. I always do it. That's one technique you should know. This is what it looks like, taking out the first branch after the endovenous ablation. We'll talk a little bit later about recurrence of veins. I usually start at mid-calf with thermal ablation if it's dilated down to that level. If not, you're going to get a reoccurrence. This is what the valve looks like. And actually, you can see right here, this is the vein, the valve. That vein is completely normal histologically. Doesn't have anything that looks different from any other vein any place in the body. Doesn't have any hypertrophy of the smooth muscle, no endothelial damage. So a varicose vein is simply an abnormality of the valve, not the vein. I think that's something important to remember. So we'll see if we can get this going.
Now, these varicosities you see here are from the SSV, so we're just going to mark them as such. We're going to do an endovenous ablation of the SSV and then do a phlebectomy. You turn your leg right this way. Each one of these bumps is a valve that doesn't work. So what we do is take out every other one, and that gets rid of them. And you can just palpate them very easily there. Because if you don't take them out, you just do the ablation, they're still going to be there. And it's really easy to do this phlebectomy, as we'll show you. We'll do a tumescent. We'll take out the first one, which is the exit. Then we'll do this one, and this one. But I mark every other one because if I see I don't get a good segment out, I'll go to just do the next one. If I get a good segment, then it's the next. I'll skip a segment. Okay, we'll show you that in just a second.
Another thing important to remember is that all branches or all varicosities empty into something. So they have to, most of them empty in either into another truncal vessel or a perforator. And so you leave that one alone because you want that to drain normally. So I don't usually touch the last bump. Leave it alone because it's going to drain. I do every other one because when you do the phlebectomy, you avulse it. The section in between actually goes away, and because there's no other communication usually with it from another branch. So you don't have to make all kinds of nicks. You can skip and save yourself some time and your patient some time.
Now the endovenous ablation of the short saphenous has been done. Start at mid-calf. Most of it was incompetent to here. This is the exit branch, the first one. So we're just going to do a little tumescent infiltration. Put about cc, a half cc in. Same way here. Every place we have a little dot, we just put this in. Okay, now we're going to show you in a minute, we're going to connect the dots.
And so the only word that I know in Spanish is pinchoncito, and we use that quite often. We have a lot of Hispanic patients. So I don't know if I use that on him or not.
No.
Now we've done the subdermal infiltration. We're just going to connect between the points. We like to have about 2 inches on each side. Veins are superficial, so you don't have to go real deep. Okay, we'll continue doing that, and I'll show you the phlebectomy in a minute.
So it's important just to be about 2 inches on each side of the mark you make. And as you see, we marked every one again. Okay, so if I don't get a nice piece out of here, I'll go to the next one. But if I get a nice big segment, I'll jump down there. Try to leave that alone if I can, because that's where it re-enters. And if it's still bulging, because it has a little bit backflow through the perforator, then I'll just foam it. That's it, and we're done in a week or two later.
Now using 11, you can use a needle, or you can use this, or you can use a punch. We just use 11 blade here. We just make about a 2 millimeter incision. We use this boil hook. It's a number 10 crochet. And you just kind of go in all quadrants to try to fish this thing out. Remember, they're superficial, so you don't have to go deep. The first one's usually the hardest to get out. This.
I'll go to the next one because it shows it coming. I don't want to spend a lot of time, so I edited this.
You can see it coming up here. And we try to remove as much as we can. We just clamp this. And we just gently rotate it. below it again. Just gently just get out as much as we can. The first one you don't get out as much because this is actually connected to the short saphenous. She doesn't feel it because there's tumescent all the way around the short saphenous. You can see now the two branches coming up.
Notice how those clamps don't shake.
What I'm going to do here, I can feel this coming down now. I'm just going to just let this go back. Now I'm going this way with it. You can see it's kind of tinted up here. So there's a couple of ways you can do this. I can actually, because it's superficial here, I can just take a blade and just divide it. As you see it, there it is. That'll actually release it more so I can get it up. Pull more out. You can see here. Now we're going to show you in a minute. I'll go on down to the next one. Because there's a long distance, so I'll go to this one next again. Use the hook. We just fish around until we can find it.
What I'm doing is dividing the branch that goes to the next valve.
Always keep the little hook up.
You can use a blade or you can use that. You can see it's
As you
divided there.
probe. Here it's coming up. So we'll show you that when we get that one out.
And here comes another one. We just show you.
You can see this one's
We've gone
coming
down
up.
now, one
It's
more.
general rotation.
Rotating it down. You try to get out as much as you can. At least get the valve out. That's where the bump is. You'll see it coming up in a minute. I think on this one.
Now this is a valve right here. You can see this is a valve. Okay. Actually, the vein in between the valves is pretty normal. It's just the valves that are dilated, and there it is, classic. And each one of these bumps is related to this. Okay. Every bump you see is a valve.
That's the valve coming up
So,
right there.
It's a process, and no one really knows why that occurs, but varicose vein is a valvular problem, not a vein problem. So we just take out as much as we can. You see we're getting a nice section out. We can actually skip the next bump here and go here. We marked here because we're going to actually take a good section out. So we just continue to march down, and that's how we do a phlebectomy.
Well, it's pretty simple to do. I mean, it takes, maybe a week or two to get your feel of it if you've never done one. But I think at least what I want to stress that, at least I think it's important to take out the first bump because that drains the distal system. Because what happens when you do that, you actually, the valve that you've taken out, the section drains into the tissue, and it drains normally into the, whatever's left drains normally into what it connects to. So you've just disconnected the circuit, where if you leave it alone, blood can get trapped and you can have hemostasis problems, you can have clotting, you can have discoloration, and more importantly, you can have an unhappy patient. Thank you.
Okay, so that's the end of the first morning session. We have time for one question if anyone has a question? If not, there's a 15-minute break, and we'll see you back here about 10:35 again. Thank you.